Okay. All right. I figured it out. That's good news. All right. So we're going to talk about sleep. Many of you have probably heard me talk about sleep disorders and psychosis before. It's incredibly important, more so than what we realized, I think. And a lot of us don't even think about, how we would define sleep, but obviously, we have reduced consciousness. Um, Memory of sleeping is kind of not there, although we certainly remember dreams. However, it's not a passive state. Our brain is not at rest, so to speak. There's active parts of the brain that are even more stimulated than when we are in our waking hours. We know we can't live without it. I know if we all were spending a week without sleep, we'd all be hallucinating heaps and bounds. And I certainly have had clients who've had hallucinations that were so terrifying, or nightmares that were so terrifying that they did everything they possibly could to not sleep. And so, of course, that would bring on the psychosis. It does appear to restore some energy to the brain. It seems to have some cleansing effect in terms of metabolism, promotes cell synthesis and repair. And we believe that it also has something to do with learning as well. So almost all individuals who have psychosis have some kind of sleep issue going on. So it's really important that we ask about that. 50 to 80% of a study done by Waters here showed that population had a diagnosis of one or more of any of these issues here: insomnia, hypersomnia, circadian rhythm disruption, and nightmares. And when we think of insomnia, it's not just difficulties falling asleep. It might be we can fall asleep okay, but we can't stay asleep, or we wake up at 3 o'clock in the morning and can't get back to sleep. That's one of my famous ones. Sometimes we can't get to sleep and then it's disruptive, or we sleep and it just is not resting us. Only 10% of the general population experiences any of these things. Come on. There we go. The diagnostic criteria for a sleep disorder includes lots of distress around it. It's long-standing, better than 3 months or more, occurs more than 3 times a week, 3 or more times a week. Not being able to fall asleep in that first half an hour, and then waking up in the middle of the night and waking up and being unable to fall back asleep when you've had less than 6.5 hours. So I wouldn't be surprised if some of you listening here today have some of those as well. Yeah, Angela, I see you nodding your head. And for those of us who do have it and we are without psychosis, that's the same kind of a deal that's happening. So Reeve and his gang did a study which was really interesting. 80% of their study population, which was 60 people with N of 60, had a sleeping disorder of some kind. So you can see the prevalence of all of the different things: insomnia, nightmares, sleep apnea. Interesting that that's so high in people with psychosis. And the number of people who had been diagnosed and treated was only 8%. So you can see how sleep may be adding to the complication of psychosis and treating psychosis. So one of the things that we know is that we all produce melatonin, and light influences melatonin. Whoop! So when the sun goes down, our melatonin production goes up and we sleep. And so for folks with psychosis, managing light in the room or environmental factors is going to be huge. And this is particularly true from the research that I've read for people with bipolar disorder, that light actually affects the cones in their eyes, and that can precipitate insomnia type symptoms, which then can precipitate a manic episode. So we want them to get natural light as much as possible, to be up during waking sunny hours, to be active, so on and so forth. As with any issue with cognitive behavioral therapy, we look at this in terms of thoughts, feelings, and behaviors, that same old familiar triangle. So some of the thoughts we have are associated with myths that we hold about insomnia. Like, I'm not going to be awake enough. I have a big thing that I have to do. I have to present at the high echo. I'm not going to be able to sleep. Oh my God, I'm not going to function. What time is it? There's the clock watching, counting sheep, doing everything that we can while all of those thoughts are going through. Our anxiety is going up, and that's certainly not good. And of course, there's the physiology involved. So drinking Cokes, caffeine, soda pop, too much sugar, smoking, of course, is a stimulant. Not taking medicines at a regular time, no exercise, so on and so forth. Illicit drugs, of course, is a big part of this for folks with psychosis. That little sheet just made it right across there. As with any other issue, we want to do a formulation, and the target is sleep. Okay, so we would actually make sleep the target of a number of sessions. So we want to find out if there's a history of insomnia or sleeping disorders, and when the psychosis started and when the insomnia started after the psychosis. What keeps it happening? What are they doing in their bedroom or not doing in their bedroom or their living space that's keeping them up? Are the lights on at night? Are they keeping a TV on at night? Is it too hot, too cold, too messy? What has the client tried? No doubt the client has tried myriad things to try to get to sleep. Probably illicit drugs, if we're talking about a population that has typically some sedatives or relaxants on hand for PRN. So some are, doing the Ativan or a Xanax or something like that. I know doctors try to limit that, but we also need them to sleep so that they're not activated. So that's, no fault of their own. There's what's going to stop that? Well, basically learning about sleep and setting the stage for a good, relaxing sleep. And of course, that's hard. They live in, oftentimes if they're not in a functional home, they're in a place where there's other people around, noise. They may not have an upkept apartment or place to live, and that can be disruptive. And of course, their own symptomology is going to get in the way. So we want to address whatever myths this person holds about sleep, and also address nightmares that they may be having, since that's such a prevalent issue in sleep. So the myths again are, I'm never going to function. I'm going to die of lack of sleep, whatever that might be. We want to really do some education around that. Some of the precipitating factors of insomnia or sleep disorders are stress, environment, lifestyle, obviously symptomology, and obstructive sleep disorder. There is night eating syndrome, which is a common syndrome with psychosis compared to the rest of the population, 12 to 25%. And of course, eating makes it hard to fall asleep. And of course, we feel some guilt and shame when we do that, or some of us do anyways. I don't, but no, I'm joking. And of course, if we're hallucinating, it's terrible. So if the lights are down, but not off, sometimes people will get up in the middle of the room and not be oriented, or we'll see a nightstand and think that it's somebody crouching in the corner. And that can be scary and keep us up. What keeps it going is napping during the day, which eventually changes that circadian rhythm. So where we're sleeping mostly during the day and being awake at night, or having that circadian rhythm kind of slide into the night. So maybe we go to sleep at 3 o'clock in the morning and wake up at 1 o'clock in the afternoon and do that kind of thing. Oftentimes there's very little daytime activity, and often there's drugs and alcohol involved. So like all of us, there's rumination, there's those dysfunctional myths that we hold on to. And the idea for most folks with struggling with insomnia is that the answer comes outside of me, which translates into I need medication. Of course, those the hallucinations and delusions on board. Our job as a therapist when it comes to sleep disorders is one, to assess for it in some way, shape, or form. Ask about it. Ask about how many hours they're getting and what kind of troubles they may be having. You do want to develop a formal formulation and talk about what it is that they think is disrupting their sleep. And you'll want to look at specific behaviors that the client does that precipitates or perpetuates the lack of sleep. A lot of education is involved. So educating about what promotes sleep, what keeps us awake, dispelling myths, for example. At each session, it's recommended that you try at least 3 strategies. And that's what this research said, but I'm going to back that up and say probably 1 is good enough, right? And so at each session, then we want to summarize the whole sleep treatment protocol. And I'm going to give you a several session protocol here as we go on. So the things we need to address are learning about it, teaching good habits, finding ways for them to be active during the day, addressing myths, relaxation, working with triggers, and somehow maintaining wellness. So that's a tall order for most of us who have full-time jobs and kids and stress outside the family. It's certainly going to be hard to address all of these issues with our population that we work with. So, and as much as it would be great to address all these issues in one session, we know that that's probably not going to be likely, but that's the target. That's what we're hoping for. So we want to talk about, these are questions that need to be asked by you and discussed with the client. What's normal sleep for you? What does that look like? What do you believe insomnia is? Do they even know what cognitive behavioral therapy is and how that might work with sleep? And, offer, there might be better chances for you to go to sleep without feeling groggy the next morning. So oftentimes goals will look like, I want to be more in control of my day. I don't want to be sleeping half the day away. I don't want to have all the side effects of sleep medication. And then we have this GUBIX thing, which I think is a really cool acronym for get out of bed if you can't sleep, stimulus control. And that goes for all of us, right? So if we can't sleep, we're laying in bed, we've been there 15 minutes. If you've been awake laying in bed for 15 minutes, it's time to get up and go do something really boring, like, I don't know, ironing or folding clothes or something until you get incredibly tired. For me, I read because I've associated reading with sleep since I was a little girl. And so all I have to do is to crack a book while I'm in bed and boom, I go to sleep. So pairing something that's relaxing or brings on that tired feeling, pairing that with sleep is the way to go. People will say, don't tell them to read before go to bed, but before they go to bed. But for me, that worked best. So, but ask them to go ahead and get up and do something about as boring as they can possibly think of. And you'll have to figure that out in the session and then assign some homework around that as well. Because who knows what's boring for them as opposed to what's boring for us, right? So that's session 1. And my guess is that might actually be session 1, 2, and 3, depending on how functional your client is. Session 2 is exploring the reasons for tiredness. It's not always because of lack of sleep. Oftentimes it's boredom, lack of exercise. There might be medical issues that are going on that we need to take a look at. There might be super big stress, and lack of vitamin D is also a big one. So most psychiatrists that I know will almost always prescribe vitamin D for folks who are feeling depressed because they're low on vitamin D, they're not getting out. And of course, being in the sunshine will help that as well. Getting active is real big. Go for short walks, stretch, do anything. Go to a group or a self-help group, something to keep them active and social and busy. And that's stuff that we know how to do. We do that a lot with our clients. So really pull that stuff in and look for social activities for this person to do, or some kind of exercise in order to get them going for the day. Also, we want to teach them about bright light. If they're sleeping with lights on, we want to teach them about that. Now, I've had people who really couldn't sleep in the dark because they would hallucinate. And so just a low light might be good, but it really needs to be low. And we want to try to get them to sleep at night as opposed to sleeping early morning to late afternoon or late afternoon to the middle of the night. We want them to be outside at least 30 minutes a day, sunshine, with sunshine dropping on your head and on your face. And of course, the cognitive restructuring. No TV, no computer. I know that's hard too. With pads or iPhones or cell phones, you can often put nighttime lights filter on that can be helpful. And then session 3, again, this can be spread out among many sessions, doesn't have to be all 3 sessions, are ways to address depression, the intrusive thoughts that come in when we're trying to fall asleep, the clock watching, any cognitive restructuring that needs to be done around the myths of sleep, and teaching relaxation. There is an experiment around clock watching right here. Harry asked about that. And it's not really a big deal. It's basically turning the clock around or covering it up, basically, so that you can't look at it, because looking at the clock makes you stay awake. So teaching the client about what's keeping the mind busy, address those intrusive thoughts just like you would with any other issue, right? Wind down before bed, taking a hot shower, sometimes wearing socks to bed can help. Motivation boost, right? So think about what's going to make this person feel better and alive in the morning. I know that's hard, but if there's something to look forward to the next day, oftentimes it can help. Chemicals and sleep and energy are intricately connected, along with the stress management that comes along with substance abuse or psychosis, right? And so we want to monitor these. I know that it's impossible sometimes to get somebody off of all of that. So harmfulness reduction is the way to go. So you do want to find an action plan. I hate that word, action plan. It sounds too clinical. Find a plan that they can follow easily and put that into action. And if there are barriers to that plan, you'll want to address that and keep on it with them until they begin to pair bed and sleep together. Nightmares are very important to address. So I imagine that many of you are familiar with Lenahan's nightmare treatment protocol, but I've included that here on the next slide in a very brief way. So that's basically taking a nightmare and having the client retell the nightmare to you, but develop a different ending somewhere along the line, and to rehearse that new ending several times a day when you're awake, and then see if that begins to influence how that dream manifests. Okay, disorientation, as I said before, can sometimes be an issue. So if that's an issue, have people put signs on their stuff. This is a nightstand, this is a lamp, to remind them. Relapse prevention for those who are in recovery and have psychosis is going to be really, really important. And for people who are striving towards recovery, substance abuse prevention is going to be really important because that affects sleep, which affects everything else. So, and for substances, coffee, for example, if they're drinking coffee at night, that's a pretty easy drink exchange, right? For something that's not caffeinated. Try to find those places and put that plan into action. Again, do the cognitive restructuring with myths and find other ways to comfort oneself before going to bed, because that going to bed time is really a time when the person really needs to feel safe and comfortable in their own environment and able to close their eyes without worry of something happening to them, which we know may or may not occur. So if you suspect medication is keeping them awake, talk with a prescribing psychiatrist about that and see if there's anything that the three of you can come up with. Use handouts, any kind of reminders that you have. Watch out for the myths and the ineffective thinking. And emphasize that we all have trouble falling asleep sometimes, and that for the most part, lack of sleep isn't going to kill us unless we're trying to keep ourselves awake and causing medical problems and psychosis as a result of that. And of course, keeping the stress low. On the appendix here, I have some resources for you. Dysfunctional beliefs and attitudes about sleep scale can be found here. I'm not sure what that is. Maybe it's this PowerPoint. And the GAD-7 is good for identifying worrying behaviors. So there we have it. That's treating disorders in a nutshell. For regular CBT, for insomnia, there is a thing called sleep restriction. And that is really helpful for the normal population if you've heard of that. It's not used with people for psychosis. So if you do some reading in this area and you come across that phrase, that sleep restriction is usually a big fat no for people with psychosis. And we find other ways to readjust their circadian rhythm. That's what that sleep restriction is about, is trying to adjust the nighttime sleeping and daytime wakefulness. All right, I've talked a blue streak. Any questions?